Hey everyone, welcome back to my channel. Thank you so much for clicking on this video. If you're new to my channel, my name is Melissa and I'm a nursing student. Okay, so today's video is a bit different because, as you can see, I am filming outside, and so I apologize in advance if any of the outdoor audio is picked up in this video. If it's really bad, I'll just refilm this, but if it's kind of here and there in certain spots, I apologize in advance. It's a beautiful day outside. I'm in a very wooded area, and so there are birds, there are crickets and cicadas, there are frogs. There's a nice breeze that's going on right now, and since there's so many trees, the breeze is loud. And also, I will go ahead and put timestamps down below on the video, so if there's any portion of the video that you want to skip ahead to or anything that you want to replay, it'll be just that much easier for you to do that. So now I'm going to go ahead and get started with the topic of today's video. So in today's video, I'm going to be comparing my experience having clinical rotations in the ICU, or the intensive care unit, versus the ED, or emergency department, or emergency room. For those of you guys that have not seen my previous videos, I am a nursing student. I'm now a senior, which is really exciting. But I am very fortunate that I have had the opportunity to have clinical rotations at various different hospitals throughout the DC metropolitan area. So I have had clinicals in hospitals in Virginia, in DC, and in Maryland. And every time that I sign up for clinicals, I try to go to a new hospital just so that I can have as much experience as possible and just a wide variety of experiences doing clinicals. And so I'm very fortunate that I have been able to have clinicals on 2 ICU units. So I did one clinical rotation in a cardiac ICU, and then at another hospital I spent time in a pediatric ICU. And I have also had clinical rotation in an emergency department. So now that I feel like I've spent a pretty decent amount of time doing clinicals in both settings, I wanted to make a video comparing the two, or at least comparing my experience and what I've noticed about these two specialties during my clinical rotations. Now, I want to start off by saying that these are two very different units and two very different specialties with two very different goals for patients. So now in the ICU, nurses are basically caring for patients that are essentially fighting for their lives. These are patients who are usually in very critical condition. They may be hooked up to a ventilator, they may have a trach, they may not even be fully conscious, they may not even be conscious at all. These are patients who they need, obviously it's intensive care unit, they need 24/7 intensive care because they are typically in critical condition. So now most patients that are in the ICU are typically there a couple of days, under a week, but you can have patients admitted in and staying in the ICU anywhere from a couple of days to months at a time. So the goal for nurses working in the ICU, first and foremost, essentially it's to save the patient's life because they are in very dire condition, so they need their lives to be saved. So they save the patient's life and then they get them stabilized enough to go to a step-down unit or to go to an area of care that does not require that intensive care. So nurses really are giving 24/7 intensive care to save the patient's life and to get them stable enough to get off of that unit. Now, the goal of the ED nurse, in my opinion, from what I've seen, seems to be completely different than in the ICU. In the emergency department, to me, it seems like the goal really is to help identify the patient's medical issue, what's going on with the patient, not diagnose, because that is what physicians do, that's what doctors do, but to help kind of figure out what's going on with the patient. And then next, they're going to help figure out the severity of what's going on with the patient. So that's when the triage kind of happens and you figure out which patients are kind of more critical than others. And then once you're able to determine the severity of the patient, the nurses seem to kind of get them stable enough to move on to their next destination. So I've noticed that with the emergency department, it really is kind of a stop along the way. It's not the final destination, it's a stop along the way. So people come to the emergency department for a variety of different issues. Patients can come to the hospital and go to the emergency department for anything from a gunshot wound, a potential fracture, to a tummy ache or a headache. It's literally such a wide variety of things. And so when they come in, I've noticed that the nurses kind of help determine what's wrong with the patient, specifically what's wrong with the patient. They measure out the severity of it, and then they either get the patient stable enough to go up, sometimes up to the ICU, to get admitted to the hospital into another department, or they get them well enough to be able to go home and finish managing their symptoms at home. So now that I've given a background on kind of the two different specialties, the goals of the nurses and the goals of the patients in each specialty, now I'm actually going to go into the differences that I noticed when I was doing my clinical rotation. So one difference was the patient to staff ratio, or the patient ratio. I noticed that it was more similar than I thought it would be. I thought that there would be, I thought that nurses in the ER or the ED got more patients, but at least where I worked, the patient ratio was kind of like, it was usually a 2-to-1 or 3-to-1. And then in the ICU, it was 2-to-1, or in special cases, it was 1-on-1. Like if the patient was very high acuity, then it was 1 nurse to 1 patient. But most of the time when I was going there, all of the nurses had 2 patients. So it was 2-to-1. And then with the ED, it also varied depending on acuity. It seemed to me like if nurses picked up some patients with really high acuity, then they would have maybe a 2-to-1 ratio. If the nurses kind of got somebody in with like a little stomach ache or something going on, then they would kind of take on a 3rd patient. And staffing ratios are tricky because it depends on the state, it depends on the hospital, so it depends on a number of different things. I have only done a clinical rotation so far in 1 ED, and that was in DC. So Washington, DC, sorry. So I don't know if that really makes a difference or not, but that's one thing that I noticed. Probably the biggest difference that I noticed between the ICU and the ED when I was doing my clinical rotations were the assessments. Assessments are a huge thing in both settings, but assessments are done very, very differently. So when I was working on the ICU, doing my clinical rotations, in both the ICUs that I was in, there was a huge focus on full head-to-toe assessments. Like I've noticed that in the ICU, assessments, you have to be good at assessments. You have to know what you're doing. You have to be on top of it. You have to assess everything head to toe. So of course you have to be doing your vital signs, heart rate, blood pressure, respiratory rate, everything like that. And then on top of that, for all of you guys that have already taken, is it health assessment? I think it's health assessment when you're doing the skills check off. The head to toe assessment that they have you do where you're checking perfusion, you're auscultating the lungs, you're auscultating the bowel sounds, like all of that stuff that seems like, are we really gonna have to do all this in the hospital? If you're on the ICU, at least I had to. Like it was so thorough. You had to check everything going on with your patient because your patient really was in critical care. And so if there was any type of change in status, whether it was vital signs, whether it was sounds with the lungs, or with the heart, you had to know what was going on. So I would have to do multiple head-to-toe assessments on my patient. I'd have to make sure that they weren't getting any bed sores, no wounds, multiple times during my, during a shift or during a day during clinicals. So that was completely different from when I was in the emergency department. So when I was in the emergency department, I was honestly doing assessments all day. I personally love doing assessments, so I had a lot of fun with it, but they were not head-to-toe assessments, they were focused assessments. And so, for example, if you guys don't know what a focused assessment is, it's exactly what it sounds like. You're kind of focusing on one area of the body instead of doing that full head-to-toe assessment. So in the ICU, where you would do the full head-to-toe assessment, in the emergency department, if a patient came in for a stomach ache, then you would do an assessment on their abdomen. You would auscultate their abdomen, you would palpate the abdomen, you would be assessing like, oh, what did you eat? When was your last bowel movement? Things like that. So for example, if somebody comes into the ED with a GI issue or a stomach issue, you're not going to be doing the whisper voice test on them. You're not going to be auscultating their lungs. You're going to focus on the abdomen and anything that could be related to any symptoms that they are mentioning. Nurses really don't have time to do a full head-to-toe assessment on every single patient that's coming in. So it's really important to listen to the patient and do a focused assessment, figure out what their symptoms are, why are they in here, and anything related to what they're telling you, that is what you should be assessing. So it's completely different than the ICU, which is much more thorough. So next is the admission and discharge, or I guess I wouldn't say admission and discharge, but I guess I would say length of stay. The length of stay in the emergency department is significantly shorter than in the ICU, just because you're not actually admitted, or your patients are not actually admitted when they are in the emergency department. They may become admitted after the emergency department if they're triaged and they're assessed and you find out that they need to be admitted, then you'll go ahead and admit them. But while they're in the ED, even though they have to do intake, they're not actually admitted. So in the ICU, they are admitted. Like I mentioned at the beginning of the video, in the ICU, I looked it up, and the average length of stay, at least in the US, is a few days. But people are usually in the ICU under a week, but people can be there months and months at a time, depending on what is going on with them and how critical they are. So it's not uncommon, at least for me. I do my clinical rotations once a week. I'd go one day out of the week, same day every week. And so usually whenever I'd go to the hospital, I would not see the same patients as the week before, but there were a few times when I actually did see my patients a couple weeks in a row, meaning that they were in the hospital for weeks and weeks at a time. In the ED, turnover could be a few hours, if even that. You're not going to have somebody staying in the emergency department more than a day. So you're not going to be seeing the same patients every single shift, versus I've noticed that the nurses in the ICU, it's not uncommon for them to have back-to-back shifts and maybe have the exact same patient that they did the day before or a couple of days before, because their patients are still in the hospital. So the next difference, in my opinion, kind of ties into the last one. I've noticed, at least during my clinical rotations, that the ICU seems to be very consistent versus the emergency department it's just so different from day to day. So with the ICU, I feel like it's easier to kind of build up a routine. At least when I was doing my clinical rotations, I had a routine every week that I would go in, and I noticed that all the nurses that I worked with had a routine. They could kind of come in, you know, you would get report, see the patient, go in and chart a little bit. Maybe you'd see one patient, administer all medications, do everything you need to do with that patient, go back to the desk and chart, and then go see the second patient, do everything you need to do, go back and chart. And so it was just very routine. It was more consistent. At least the ICUs that I worked in were both specialized. So one ICU that I did my clinical rotation in was a cardiac ICU. So all of the patients on that unit or in that unit were cardiac patients, and they were critical care cardiac patients. So pretty much, not all of the medications were the same, but they were kind of the same, like 5 to 10 medications that all of the patients were getting, just in different dosages at different times. And so you would kind of see the same medication pop up, not too many brand new medications, not too many brand new conditions. All of the patients on the unit they all had cardiac issues. It was kind of almost like various issues of the same condition, if that makes sense. So it was extremely consistent, versus in the ED, anything goes. So you could have somebody come into the ED, like I mentioned, with a gunshot wound or a potential fracture, anywhere to like a stomach ache or a stomach virus. You don't know what is going to walk into the emergency department, especially living in the US. For those of you guys that don't know, I live in the United States. Just the way that our healthcare system is set up, not everybody has insurance, not everybody has healthcare literacy, so not everybody's even familiar with really how our healthcare system works and all the different options that they have. So there are a lot of people, I think, depending on what area you live in, there are a lot of people who will go to the emergency room when they could have just called their primary care physician, or they could have gone to a local urgent care or a fast track or something like that, because they either don't have insurance or they don't really know any different. They're feeling sick and they just go to the emergency room when they really have other options that they're not aware of. So because of this all adds to anything, anyone, any issue can walk into the emergency room. So you can really be faced with anything. So because of this, every day is going to be different. Every shift is going to be different. Every clinical that you go to is going to be different. Every hour can even be different. So you can walk into your clinical rotation first thing in the morning in the emergency department and things could be very slow, and then by noon things could pick up and things could be extremely crazy, and then by the time that you leave things could start dying down. If it's like a holiday weekend, things could be insane because people are at home being reckless. It really, every single day, every single hour in the emergency department is just, anything could happen and you just kind of have to think on your feet. It's kind of crazy. It's fun if you like stuff like that. I love stuff like that. But it's so drastically different from the ICU, which I feel like is very organized and meticulous and just very consistent. The ED is chaotic and all over the place, and you never know what you're going to get. And then along with that, like I mentioned, a lot of ICUs, at least in my area, are kind of specialized. So maybe you'll have an ICU that is focused on cardiac patients, like a cardiac ICU, or you'll have an ICU that is focused on neuro patients that have neurological issues. So you'll kind of be administering the same medications and you'll kind of be seeing the same medications, versus in the ED, since you have such a wide range of issues, people can come in with anything. I noticed that every week when I was in my clinical rotations, I was administering new medications, I was seeing new medications, I was dealing with medications I had never even heard of, and I would have to look it up. So it was a great learning experience, but I feel like that can be stressful for somebody who would rather just kind of know maybe like a dozen medications really, really well, know what they do, know their adverse side effects, know all of that. I feel like that would be somebody who's great with the ICU. If you're somebody who kind of likes to see a wide range of things and see new things, I feel like the ED is really good. So while we're on the topic of medications, that brings me to the next major difference. While I was doing my clinical rotations in the ICU, I think all of the patients that I saw were getting IV medications, literally every single one, versus in the emergency department, I think I only saw one IV med being administered. The rest were all oral medications or topical medications. So in the ICU, since you do have the high acuity patients, many of which may not even be conscious or they may not be able to swallow, they have to get IV medications. And then in the ED, a lot of people come in, like I keep saying, headaches and stomach aches. That's because I saw a lot of headaches and stomach aches in the emergency department, but they would just take oral medications, they would take pills, or if they had a rash, they would take topical medications. So now for my personal preference, if anybody cares to even hear it, but between the ICU and the emergency department, to be honest, there were things that I liked about both of them. And when I'm working as a nurse, I think I'd be happy working in either one. I like different things about both, so I really can't choose one over the other for which specialty I'd want to go into, because I would love to go into either. But specifically when it came to my clinical rotations, if I had to choose one, I would choose the emergency department that I preferred far more than the ICU. The emergency department was like, it was so fast-paced. And one, I love doing assessments, and it was just like assessments all day, focused assessments, which I thought were cool, but it was just assessments all day. It was fast paced. And so it made my 12-hour clinical rotation go by so quickly. For those of you guys that are nursing students, depending on the hospital that you're at, the nurses you get partnered with, the clinical instructor, sometimes those 12-hour clinicals can drag on and feel like an eternity. So anytime I find a rotation that the day goes by quickly, I love it. And so the ED was definitely a rotation where the days went by, it felt like 2 hours and I was there for 12 hours. Just because there's so much to do and you're constantly on your feet and it's so busy. And then also, I found the ICU units that I worked on to be extremely rewarding, but it can also get very depressing. The ED can honestly get depressing too, and it comes with its own challenges. You hear awful stories in the emergency department sometimes, especially when Child Protective Services has to get involved, or if there's some type of domestic violence, both of which I have unfortunately witnessed. You do see a lot in the ED, but I feel like in the ICU it can be very hard when a patient isn't doing well, and you never know. I don't ever want to play God, just because you never know what his plan is. but you can kind of tell when a patient most likely is not going to make it out of the hospital, and you just kind of can tell that they're probably not going to make it, no matter how hard the nurses and the physicians are working to save them. Another difficult thing is when you can tell the patient's going to make it out of the hospital, but they're probably never going to return to what their baseline is. Like, they're never going to be who they were before whatever incident happened to them. I feel like that can be really, really hard in the ICU, versus for me, I feel like it's easier for me to deal with the challenges in the emergency department. But the ED can honestly be a lot of fun. Like, so in the ED, like, people come in with all sorts of backstories, some of which are sad, but a lot of which are just like funny or crazy. And to me, I kind of think it's fun when, like, I don't know, it's kind of like starting a movie or a book, like right in the middle, like right in the climax, right at the interesting part, and then you get to be a part of it for a little bit, like a chapter for however long, and then it finishes. Like, to me, that's really cool. Like, you kind of intercept with somebody's life at a very crazy time because they're in the ED. You help them up, you help get them patched up, you maybe talk to them, get to know them a bit, and then you send them on their way. Like, to me, that's really cool. I think it can be hard because you kind of never get the end of the story. Like, there's some people that I've met throughout my time in healthcare where, you know, you help them for a moment in time and then they go off to their next destination, which is very much what the ED is. You're helping somebody get to the next point. So it can be hard if you're somebody that needs to know how the story ends, because you're never going to get that. But if you're okay with that, then I think that it's a really fun area to be in. So that is it for this video. If you made it to the end, thank you so much for watching. If you like this video, please go ahead and give it a thumbs up. If you have any questions, please just write down in the comment section. Otherwise, I will see you guys in my next video.